you and everyone.
Absolutely. Em, thank you so much for joining us today. It is, yes, Purple Thursday. And I'm talking about a hidden hero today. Honestly, like almost the unthinkable, unspeakable kind of stuff, the poop, the pee, the sex. I'm sorry, we had to say it right off the top. And nice picture in the background there, girl.
Isn't it lovely? We want people to know about their anatomy.
Well, I really want to ask you to join us today. Again, just a real quick update. Emily's a physiotherapist with Collegiate, and she's been with us now for a number of years. And she actually went into physio first, obviously, got into pelvic health physio, which is really something that I'm going to let Emily talk about. But Em's gal from the Red Deer area who's got an amazing love for activity and sports and her dog Blaze. Em, I don't need to go into too much, but I really want people to kind of get. Is there anything else you'd like to add about you, Em?
No, you pretty much summed it up. Let's keep it simple.
Okay. Well, I just, if you ever get a chance to meet Emily, I think one of the biggest things about pelvic health is fear of being vulnerable and being open about stuff that's very uncomfortable to talk about. And I think you're very easy to talk to, and you're very, very gentle and caring. And I think that's one of the things that makes you an extraordinary therapist. But when we're talking about stuff this kind of, let's call it dicey, so many people are so afraid to be open, and I'm one of them. And I think that that speaks volumes to you as a person, as a therapist. So that's maybe where I'll leave that then. If today there's something that does speak to you, please don't be afraid to reach out to Emily. So yeah, let's get into the meat and potatoes of things. First of all, I think it's important that we maybe talk about what is pelvic floor and do. Like,
yes. So that's always the best place to start, because we shouldn't talk about something if we don't know what we're talking about. So to keep it as simple as possible, I'm going to show you the model. And when we do have a session, I do go into sometimes a little bit more detail. It depends on the person, but it's a group of muscles. So from the pelvis here, we've got 3 layers. So the first layer is our sphincter layer. That's going to be, the anus, the vaginal opening, or the introitus, and then the urethra, and then our clitoris. That's kind of the first layer to keep it simple. Second layer is going to be connective tissue and a little bit of like fascial slings and a little bit more connective tissue. And then we have the bowl, or the strong pelvic floor. And then on the inside, it holds our organs, our pelvic organs. So it has the bladder in front. It has the rectum in the back. So we'll take that out. It has the uterus. And then we have the bladder. Now for males, they have the rectum and the bladder, but they're not going to have the uterus. So it's just a little bit different. But it's a group of muscles, and it does a few really main things. It's a sump pump, so we have blood and lymph from the upper body that moves down through the legs and comes back up. And then we have, so from the bottom coming up as well. So it's a place where there can be a lot of congestion. So we do just want to make sure that we move our body, and so it doesn't get stuck in that area. Like Mel said, it's big in incontinence. So if those things aren't working, we can have leakages with overactivity or underactivity. And then the sexual part, we want to have good sex in general if we are sexually active, and so it can help with that blood flow, and that healthy tissue can help with good sex life and better orgasms. It also it has 2 structural things. So, right, it's at the bottom of our spine. So we're going to have the support helping the spine and the pelvis to support everything over top of it. And then it also is going to support muscularly, it's going to support the insides of our body, like our intestines and everything. So in a nutshell, that is the pelvic floor. And just a quick note on that. It's because it's so central, you know, when people talk about those tight shoulders or they grind their teeth, the pelvic floor is just another place where we hold extra tension. And so it does require a little bit of attention sometimes too.
Okay. Mm-hmm. Cool. Well, thank you for that. That was, yeah, interesting. All these pieces. You know, I think one of the questions, I know for me anyways, is like, what types of problems might people be having? Like, I mean, wouldn't even know who to send to you. And I think all of us listening are kind of like, well, I've got things, but I wouldn't think about going to get treatment for it. So first of all, let's not talk about treatment so much, but maybe some of the things that treatment could help for, and just some of the stuff people might be struggling with. Like for me, let's just put it out there. I've always had issues with my bowels being a little bit slow, and there's nothing, no amount of exercise, water, fiber that seems to change that. And so I'm guessing that's one of the issues you see is constipation. What else?
Yeah, so constipation, and I mean, we could talk elaborately about constipation. Like, it is huge, and the amount of things that, you know, play into that. So absolutely constipation, and then we work with a team. So we do all the things that we can. So we work on the muscles, and again, we won't get too much into treatment, but we do work with the docs and sometimes naturopaths to really get on the gut health, because it's all related to each other. We see a lot of incontinences. So there's stress incontinence, which is going to be when you cough or laugh or sneeze or run or jump, any kind of activity, big or small, that you get leaking. And it could vary from dribbles. It could go like a full pad's worth of fluid. And either of those, it doesn't matter what end. Obviously, the heavier the flow, the worse you think it is, but none of it is normal. It is something that we can help with. And then urge incontinence is that overwhelming urge to rush to the bathroom, or you have running water, or you go into the cold, and there's different triggers for different people. Key in the door is a big one, that all of a sudden there's that rush that you're like, yeah, right, you have to go pee. And it's often a nervous system driven thing where we have to just retrain reflexes that we've somehow lost, whether it was from sometimes a trauma or just stressors in our lives. But we work with that whole system for those kind of incontinences. You can have a mix of incontinences. You can have overflow incontinence, but that is like for a neuro patient, someone who had a stroke or someone who's in a coma or something. Overflow incontinence, they just don't have the control or the awareness or the senses, and so their bladder gets full and it literally can't hold anymore, and so it comes out. But we don't see a lot of that in our setting, in our private setting. Things like we see postpartum, we see any time in that pre-postnatal time. Those are huge people. Pelvic pain, whether it's pregnancy related or just period, any kind of pain, period pain as well. And then we have menopause related things. So a lot of times with the hormone shifts, so even young girls, like, they can have issues, but they haven't been informed about their bodies yet. So they don't know what is normal and what isn't. So we are here to kind of guide them if they do need a little bit of help there. Yeah, so pelvic pain, unremitting low back pain is a big one. And I think we can talk about it a little bit more after, but a lot of people with back pain, they've tried everything they possibly could think of. They tried chiro, massage, physio, and there's just sometimes a missing link, and that missing link might be that inner body, that pelvic floor, and that whole system that we work on.
Okay. Mm-hmm. So painful intercourse as well. I'm just trying to think of some of the things that you've mentioned to me before. Men having issues with their blood as well.
With what, sorry?
Men and women having issues with their blood as well, with jumping and the urge incontinence stuff. Okay. So I guess that brings me to my next question. So you mentioned, or we were chatting a little bit about maybe what other types of specific things can males, be dealing with? Is it the same kind of stuff exactly? And are there treatment options that you can offer to this population as well? Because obviously, I have a hunch that, I don't know, and maybe I'm wrong, but a lot of women are already nervous to show up with these types of issues. So let's just chat a little bit about the male population.
Absolutely. There's a few things, big ones that we see is post-prostatectomy. So there's obviously going to be a disconnect and some scarring and some tissues that need a little bit of rehab. With that will sometimes come erectile dysfunction and incontinences. So there are, right, there's stats. I don't have the stats handy anymore, but there's a huge range of, I think it's like 8 to 80% or something crazy like that of people that have incontinence after a prostatectomy, and we can get them back to a certain point. And it is cool, the changes that men can make. But a big thing that we see with men is overactivity, right? So they don't have the 2 hiatuses, right? They don't have this big, genital hiatus. So they have overactivity, and then that causes pain. It causes constipation. It causes these weird things to happen in that area, and then radiating pains into their groin or their back or their abdomen. Abdomen surgeries. So if they've had any kind of repairs, if they've had hernia repairs, those are things that we'll see also, because those muscles surrounding it, like our inner thighs, the abdomen, any of the hip muscles as well, they can just really tighten up, and we want to pay attention to them and help to calm them down. High stress jobs, high stress situations, so like moving from another country, coming here, there's all these different things. There's a lot of psychosocial things involved that need to make sure that we're addressed. But they almost all will lead back to something to do with overactivity in the pelvic floor or disconnect to the pelvic floor post-surgery.
Okay, and what about testicular pain?
Yeah, so that can be part of it. So we can have like actual prostate pain when it's enlarged and it's swollen and it's pushing on things. And then, so I will say I don't see a lot of specific testicular pain. It's usually the pelvic floor muscles, but it will radiate to the testicles. And then, but yeah, it is definitely something that men can suffer from. And if we want to find the driver, so is it the testicles that are the problem, or is it something in that pelvic floor that's referring into them?
Okay, thank you. Maybe can you go back into the female population for a second, looking at like postpartum, pregnancy, menopause, hormonal kind of components, just kind of the sky's the limit there a little bit. Any comments?
Yeah, so let's start with the pregnancy. So, right, we start our cycle in our early teen years usually, and then we have babies, and then we go to menopause. So there's these different stages for women that we have massive hormone changes, and then it affects our body. And we really notice it as females, and males aren't going to have those same, they'll have different changes at puberty. But for just skipping back to the postpartum, prenatal postpartum, there's a lot of hormones, and it's not all about the hormones. There's structural things, there's hormonal things, there's, again, that psychosocial factor. But with pregnancy, we do recommend, so it's like experts are recommending, and in Europe, they're doing a really good job of this, but you should see someone during your pregnancy to know what your baseline is. And if you have things that are going on in your body, like maybe there's an undiagnosed prolapse. So a prolapse is when tissues are pulling down into that vaginal cavity. We can help to manage that, to make your pregnancy good, and to make sure that your delivery, that you're doing all the right stuff in your pregnancy and delivery to help postpartum as well. So it is recommended to have that early checkup, and then 35 weeks into pregnancy, and then 6 weeks postpartum is also recommended. And it's not like that 6-week mark. A lot of people just think, oh, after 6 weeks, I can have sex again. I can do anything. I can do my high intensity interval training. I can go back to running. And it's not the case. It's actually in the 2019 guidelines for postpartum, they came out with, they say 12 to 14 weeks at least to wait before going back to those high intensity things, including running, because sometimes the tissues are just starting to get happy at 6 weeks and they need more time to do those higher things. Really want to get connected to that, get slowly connected to that body, and then progress those things.
And is that the same for sex as well, Em?
Yeah, so, and it ranges, right? Some people have very easy births and they have very little scarring and very little pain. Maybe their vaginal canal isn't quite as sensitive either. And so they can jump back into things before even we've said to, and they have no issues. And then you have the other side where they've done everything right, but maybe they had a forceps delivery, or maybe they had like a really traumatic birth, or they had a huge baby, and they do need a little bit more time to heal. So we look at the tissues and we see, hey, what is going on? Do we need more time? And I can help to see, like the doctor will tell you if they think you're safe, and then we'll tell you a little bit more regarding all of the other tissues. And if there's any kind of sensitivity, we work on that. We can do it manually. We teach you how to do it. And then we say, okay, let's maybe hold off on sex for a couple more weeks, and then we can try it again when the tissues are healthy. It's really just like any muscle group in the body, any kind of surgeries, right? Pregnancy and postpartum, like birth is a surgery, right? It's a huge change to that body. So we should treat it as an abdominal surgery or an ACL, different than ACL, but you know what I mean. It's definitely a huge change in the body that needs more attention than they give it.
So really look at it as any other soft tissue, and as an injury is kind of what I'm hearing you say. Now that makes perfect sense. And of course, everybody's different and every injury is different. So they need to be, I guess, treated differently and given their own rest and recovery times.
Yeah. So
is there anything else you want to talk about in those areas? Like, how about menopause? Is that
Yeah. And again, that's a whole talk on its own, but the same idea with the hormones. So estrogen is a big one, right? When we start losing our cycle. So perimenopause can start as early as age 35, and you can start skipping periods. You can start having these changes that happen, but menopause is one day. It is the day after 1 year of having no period. And so after that, you become postmenopausal, but the perimenopause is that whole zone from whenever you start having weird symptoms or different changes in your period cycles to any time postpartum or postmenopause. So the hormones, right? Estrogen drives pain. Estrogen drives our heavy symptoms or heavy bleeding or pain during our cycles. But it also, right, into menopause, we can have dryness. We can have like stretching or loss of integrity of those tissues. And so we need to pay attention to them and make sure that they're as healthy as possible. Tendon issues, right? There's literature coming out that talks about the hormone changes and how all these women are getting gluteal tendinopathies, Achilles tendinopathies. I don't remember if patellar tendinopathy was in that group, but there's a lot more going on hormonally at that time that people need to pay attention to. Just general people, but also us as physios and healthcare practitioners. You got to look at the age of your people and what else is going on in their life.
Okay. No, thank you. I see a few people joining us as well here and there. So just if you have just joined us, we're talking to Emily Nadon about the hidden hero, the pelvic floor. And yeah, just a couple more questions here, Emily. Obviously, people want to get and wondering, you know, what can do themselves or at home or self-check or some strategies. Can you elaborate or give us some tips there?
Yes. So in a session or whenever we just talk general about the pelvic floor, we always want to start with, right, knowing where it is. So we did talk about that. Again, it's at the bottom of the pelvis. We have our pubic symphysis, our coccyx, so the base of the tailbone, the front cartilage and front pubic symphysis, and we have our sit bones. So if you're just sitting, and maybe just try this with me, Mel, sit uncross-legged, so feet flat on the floor. Wiggle your hips forward and backwards, side to side, until you can feel those sit bones, and then sit directly on them. And then you want your pelvis to be kind of, we call it neutral, right? So you're not tucking your bum under, you're not sticking your bum out too far, you're just upright. And that's where we would start. And again, no one is going to stay neutral 100% of the time. That's so unrealistic, but it's how we start. And then we move from there and we come back to it. And we move and we come back to it. So find that neutral, and then put your hands for me on your lower ribs. So your lower ribs or onto the front of your tummy, okay? And then once you're there, so in that sitting position again, Mel, now that you have your hands there, find those sit bones again, and then slowly take a breath. Nice and slow and calm and safe are keywords that we use. So it's not like it's a slow breath into that area, right? Downward, and see if we can start feeling that pelvic floor. So, and we do use a lot more cueing in clinic. We talk about the diaphragm and the piston that is in the internal canister. So I won't go crazy into that today, but just start by feeling it, by thinking about your breath, moving your breath down into your belly, into your lower ribs, and then into that floor.
So don't have my ribs expand, or do you expand?
Have what, sorry?
Do you want my ribs to expand or not to expand?
I want your lower ribs to expand. And if you notice that we're moving this, so let me just, I will stand for this, but I want you guys to be sitting. So if you're doing this, and my hands will move if I'm breathing into them. So, okay, but watch what happens if I breathe into my chest. Everything moves up instead of moving down. So we want to make sure that the diaphragm's only job is to contract and open up space for those lungs, the biggest part of the lungs, to fill. So if you're breathing up, then we're not moving the diaphragm enough. And if we're not moving the diaphragm, then we're probably not moving the pelvic floor either. So we want to make sure that our breath expands into that pelvic floor, into all of our abdominals, and then recoils back on our exhale. So that's what we start with. And again, that was a very quick talk. We go into a lot more detail. I feel a lot of stuff. I help with cueing to really get into it. But just sit in a chair, start to feel where you breathe, and start to move your breath downward into the pelvic floor and into the belly. And that's the first place that we would usually start, is our basics. You can look at your alignment. So check in. What are your shoulders doing? Are they forward? Are they really, really proud and overly proud and right, like arching backward too much? We want to bring that ribs over top of the pelvis, because then that's in our, again, proper alignment. But that's not for all day, every day. That's to get in tune with it. And again, we move out of it and we come back to it. Other things that you can do is figure out what's going on. Like if you're constipated, then start doing things like talk to your doctor, or right. We talk about magnesium, we talk about Restorelax, we talk about fiber, but it's not everything. Every single person can have a totally different reason for their constipation. And so just making sure that you try to do the things. And if you need help, right, you can, you know, the internet has information, but it is scary how much information is on there. And a lot of it is outdated, and some of it is just plain wrong. So if you do struggle with that, make sure you do try to figure something out, talk to someone. Constipation can be a driver to incontinences as well, because it can actually push on the bladder from the back of the vagina. What else can you do for yourself? Be kind to yourself. Just really check in if you have a high stress job, or you're running around after 3 kids, or whatever your life looks like. Try to find some time for you and just take a few breaths in a day. And you could be laying, you could be sitting, go for walks, right? Start to just do things that feel good for you. Self-care is huge. And if we can start to calm down our whole system, our nervous system, we can start to calm down that pelvic floor as well. Just getting connected to our body is probably the biggest starting point, I would say.
Okay. Now, in terms of treatment, like, I mean, what could people expect? Like, is it manual therapy? Is it exercise training? I know every injury and condition and situation would be different, but like, what could I expect? I mean, obviously there might be some internal I'm guessing, some palpation, low back, pelvis, but what about treatment?
Yeah, so absolutely. And that is something for you to know, for everyone to know, that there is a portion of an internal exam, either vaginal or rectal, when you come see us, but we do a lot with what your history tells us. So we don't have to start with an internal exam if you're not comfortable, but it's just like any other muscle. If you're hurting something, we want to get to it. We want to feel it on your skin, or like, you know, don't just feel the shoulder through the shirt, actually feel the shoulder and see how it's doing things. So we want to feel the floor, but we can do a lot without necessarily going in to start, even though it is still that gold standard. So yeah, we would do some internal work. We would feel your stomach. We would, if depending on your symptoms, we'll go into alignment, we'll go into what's going on in the low back, what's going on in the hip muscles, a lot of backside and front and inner hips, so pretty much everywhere in the hips we want to pay attention to, and we'll do some work. We'll do some manual therapy inside, we'll do some manual therapy outside. We'll do exercise prescription. We'll give some techniques if there is constipation. We'll do some self-massage techniques if there is vaginal tightness, or if we need that retraining. We do some lengthening, some self-touch. There's a lot of things that we can do to help with those things. But yes, manual for sure, and then self-manual care afterwards as well.
Okay, and it sounds like treating the pelvis and low back. Classic physiotherapy is often incorporated, it sounds like, too, based on what you said. Oh, can you hear me okay? I'm not sure if I'm, yeah. I have one more question. I know we only have a couple minutes here, but I do see if anybody's got any questions, you can throw them in the chat. I see Forest Massage and Wellness, hi Danielle, has put in a training helpful too. Is there something that you wanted to mention about that, Em?
About what, sorry?
Bladder training is to
yeah, so if there is so urge incontinence, right, if we're doing that rushing or we have those triggers, we would work with that body system. We work on breathing, calming down when we have that urge, and literally telling the bladder to shut up and say that we're in control and you don't actually have to go pee right now. And you want to think about your intake. So do you actually have to go pee? Do you actually have a full bladder? Did you drink this whole thing of water in one sitting? Then it's probably going to be full sooner, and you'll have to go to the bathroom more often. But we try to retrain the bladder so that we're going at a normal interval. So normal looks like every 2 to 4 hours in a regular day. 1 to 2 times at night is considered normal. And so it could be 5 to 8 times. Did you hear?
Yeah, sorry, 1 to 2 times during the night is normal? Oh.
Yeah, is considered normal.
Okay.
And then so every 5 to 8 times a day, and sometimes it can be, right, we can have the low end, so sometimes nurses, right, you gotta hold it in sometimes, and so that can have its own issues that can happen. But yeah, if you aim for 5 to 8 voids of your bladder a day, that's quite happy for the bladder, and it should have enough time to fill. If you're going 12 times, then you're probably letting the urge win, and you could do some calming, some breathing, and we would do some squeezes, some Kegels for that as well, just to retrain the bladder and the body together. Yeah, no, that's what to keep it simple, the bladder retraining, that's how we would start. Okay.
I know we might go a minute or so over here, but we're right at 9 o'clock, and I have one more question for you. I know it's probably, maybe it's frustration, I'm not sure, but we do see a lot of people, whether they're friends or wherever, the idea that, hey, you know what, just go and do some Kegels or however, to say them, and you'll be good. So I'm sure that's probably a bit of a frustration for somebody with all the background that you have and knowledge in this area. But what about them? What do you have to say about them?
That's a very long question. So the problem with them is that people are giving them as a kind of umbrella, just go do Kegels. But it's just like if someone told you to go do bicep curls, and that's just one part of your upper body. Like, you're missing a whole spectrum of muscles if you're just working on one muscle group. So we talked about that pelvic floor. It doesn't work by itself. It has that diaphragm, it has the abdominal canister around that, so we call it the internal canister. And so everything works as a system. So if you're just doing Kegels, you're kind of just missing the boat. And you could be doing the right thing, but you're not doing it coordinated with everything. The other thing with Kegels is sometimes people have that overactivity and they need to stop doing Kegels, and we need muscles to lengthen fully, to go through their full range of motion, and to contract. So they do both things. And if you're only doing this and you're not lengthening it, then it can't work properly. And so we see people that are just like, oh, I'm doing Kegels, but I'm still leaking. And it's because the muscles are like this. And as soon as you try to if you sneeze and you leak, those muscles are not able to turn on to support you. They need to actually lengthen, and so that when you do cough, they have the ability to turn on and hold it for you. So they are overprescribed, and they are valuable, but they need to work as a system. So we would usually work on lengthening and getting connected to that floor first, and then we reincorporate the Kegel as needed for those people that are having trouble either connecting or coordinating. For exercise, Kegels are important, but again, they have to work with the whole system instead of just squeezing the whole time. You're going to run into problems if you're just holding that the whole time.
Right. And I have seen a few people, I did some pelvic health courses years ago, and I know that I was doing some external work only, but there were some clients would think that they're squeezing or pulling up, but they're actually pushing when they're doing it. And so I think that kind of speaks to what you already said. Sometimes people just aren't even doing them right, and maybe making things worse in the fact that they need them, but just a few different cues to be able to get them that they're working, right?
Yeah.
Okay.
So if you are doing Kegels, it shouldn't be like, I shouldn't be able to see you move if you are doing a Kegel. It should be very, very central, right? And it should, one of the cues we use is pull your sit bones together. So you're just thinking like this, and it's very subtle, right? And that's why we got to get connected, because if your outside body muscles are loud, they're going to turn on first. So we have to listen. We have to really calm things down and pay attention to that small part, because it isn't big. It's not a lot of movement. They're small muscles, but they are meant to do a lot of work for us. So yeah, it is a very small contraction, and a lot of people do them wrong. But if you are struggling with them, stop them immediately, work on breathing, and then try to put them in together with your breath.
Okay. Well, Emily, that was amazing, and I know it's hard to cram all this stuff in half an hour, but sounds like the pelvic floor is really this hero. I mean, it's doing so much, and it can impact our lives in really positive or negative ways. So I think to allow it to have a positive impact on us is really important, because it can, whether it's reducing pain or enjoying even just a trip to Calgary without having to feel like we need to stop to go to the bathroom or something like that. So if anybody is interested in getting an appointment with Emily, Em, I want to make sure and let people know where to find you. Emily's at the Collegiate Sports Medicine campus location, and she does booking online as well. But we'll also, correct me, I think you'll do a consult over the phone if they have questions or you if they're nervous or that's cool. Okay. And other than that, if call or an email communication, ask her a few questions and get a few things started. Obviously, she can't be giving too much information over the phone. Crosses over into client visit and liability and stuff like that. It does need to probably be in person, but at least to kind of, there is information on our website about pelvic health. So I think do yourself, and I will as well, and I promise, a big favor and take care of yourself and yeah, just reach out if needed. Is there anything else you wanted to say?
No, I think that about covers it for today.
Okay. All right, guys. Well, happy Thursday, and yeah, we'll let you off the hook. Bye, guys. Bye.